Thank you all for joining today. Like Shannon was saying, I'm at Idaho Neuropsychology. I have been here, set up the trauma treatment program as well as the chronic pain program here. And prior to that, I was almost 15 years with the VA, helped run the PTSD clinical team over there and helped establish the TRC, the residential program over there. So some people may know me back from those days. But excited to be touching base on evidence-based psychotherapies for PTSD and when to look at each one symptom-wise, talking a little bit about trauma, all the things. Next slide, Shannon. This harkens back to my years at the federal government, but I always do disclosures because yes. So I have none, and the opinions and information presented in this presentation are my own, which was our tag thing we had to do in the government all the time. It's kind of burned into my brain. Next slide. So what I want to talk about today is post-traumatic stress injury, what makes it become a disorder, and then focusing on the tale of two traumas, best treatments for symptom presentations. I wanted to make sure I spoke a little bit about occupational trauma here just because of the primary care setting that the majority of y'all are in, and making sure that we kind of touched on all those pieces. So go ahead, next slide. So the two cases that we are going to weave throughout the presentation today are two folks who have both had occupational injuries. First case is an early adult female. She's a law enforcement officer. She had a trauma that was the result of a motor vehicle accident in response to an officer-involved shooting. And this individual was referred after over 6 months after the injury. And case two is a middle-aged male truck driver, also a motor vehicle accident, both physical and psychological injuries with that, and was referred within 3 weeks of the injury. So when we're looking at referral timelines, that one was much sooner. Go ahead. We know that occupational trauma kind of presents a little bit of a different slant when it comes to who we're seeing in with trauma, with injuries at the workplace. Research shows that approximately 1.5 of workers reported being involved in a disastrous event or accident at the work. And honestly, probably underreporting a bit, but for those of you in the workman's comp world in Idaho, there are a lot of cases, and the injuries can be pretty profound. We know that occupational groups such as healthcare workers, police officers, prison workers, so corrections officers, emergency personnel are all at increased risk of experiencing traumatic events that make them more likely to develop PTSD. And the big piece of the cumulative aspect of the trauma that they're experiencing in those occupations really impacts how they continue to have resilience, how they continue to experience what they're experiencing, and it can lead to social and occupational deficits in functioning, early retirement, job loss, and in extreme cases, we see often higher suicide rates in those occupations. Go ahead. So when we're talking about post-traumatic stress, and I guess I should probably have started by saying I'm not going to dive into every possible scenario here. I'm not going to dive into every incident that one could think of. If you have questions as we're going through, I'm a person who feel free to throw it in the chat. I'll try to kind of keep my eye on the chat as much as possible. But when we're looking at response to accidents, post-traumatic stress is completely normal. So for folks who have experienced something in the workplace or experienced something outside of an occupational trauma, we would be expecting them to have a physiological response, avoidance or fear of the event. They may have nightmares or intrusive thoughts. All of those pieces are completely normal after experiencing a traumatic event. Normally, in most cases, we see that symptoms subside within a month or two for most people. And they start having less intrusive thoughts or nightmares. They start having less of the physiological, like the hyperarousal reactivity. They're not as jumpy. There's not as much startle response. And they tend to see a shift in their cognitions or their thoughts or experiences of like what they're thinking about the event, the causes, responsibility, all those things. We tend to see shift within a month or so. Go ahead. For the folks, ooh, this one looks tiny. Sorry for the small writing, y'all. For the folks who don't have that shift, when we really kind of boil down to it, PTSD is a failure to integrate new information into the system. Their brain is trying to make sense of something that happened within the frameworks that they had of understanding the world. And so when that when that processing of the information and making sense of it and all those pieces don't occur, the symptoms will raise to a level of impacting their social and occupational functioning. So what symptoms are we talking about? For an overview, there's 4 symptom buckets for a diagnosis of PTSD. And we need to see all 4 of them in order to have the diagnosis. So the first bucket is the re-experiencing symptoms. So this is the intrusive thoughts that pop into people's head when they don't want to have those thoughts, the nightmares. This is also where we see flashbacks. Flashbacks are not as common as the re-experiencing thoughts. I'll often explain them to patients as when it's the intrusive thoughts, it's you know your feet are in Boise, but your head is back wherever the trauma was. And for the flashbacks, it's your head and your feet are back wherever the trauma was, and you don't realize necessarily where you are in the moment. Avoidance bucket is exactly that. This is the one that unfortunately gets the strongest with practice. This is avoiding people, places, things that remind them of trauma triggers. This is avoiding any emotions or thoughts that are related to the trauma. So can really start impacting life in a lot of ways for people. Negative mood and cognition. Sometimes people assume it's separate depression. It definitely looks like depressive symptomology for a lot of people. There's decreased connection with people they love. There is negative thoughts about guilt, blame, shame, feelings of fear, helplessness, horror. Like I said, loss of connection of people that they used to like really feel connected to, not doing things that they used to love. The hyperarousal bucket is the physiological response. So this might be jumpiness, startle response. This is people who maybe are taking more risks than they would normally take. Anger and irritability increased, impact on concentration, and sleep fall in the hyperarousal bucket. So in order to get people from PTSI, post-traumatic stress injury, or just experiencing PTS, to PTSD, we need to see all 4 of these buckets become in impairment in their life. There's also 30 days from the incident, and this is important. I could rabbit hole this, and I'm going to try not to, but in workman's comp cases, when we get people in really quickly, we can't diagnose PTSD if it's less than 30 days from the incident, which for our first responders is a really big piece of whether their care is compensable or not, because they have to have a diagnosis of PTSD. They can't have things like adjustment disorder or acute stress disorder, things like that. And so we have to watch in the world of workman's comp to make sure that where we're at in terms of what we're diagnosing and making sure that we're within the realm of post 30 days from the event. Go ahead to the next slide, please, Shannon. So what do we know about PTSD statistics? We know that most people who go through trauma will not develop PTSD. Like I said, post-traumatic stress is really normal and natural. And as much as I wish that trauma would not exist in the world, it does. And people's experience of trauma is going to be different. For some people, They might experience things that feel like a big T to them, whereas it's a little T to others. And we look at that piece. The other criterion that I did not put on the past slide is the criterion A, that you have to have experience, like the qualifying event that is the criterion A. So either fear of or experience of significant injury or death, or violation, and or the cumulative aspect of exposure to trauma as a result of your workplace. There used to be a piece of there needed to be fear, helplessness, or horror in past iterations of the DSM, and that was taken out. That impacted our veterans a lot because they did, for some of them going into combat scenarios, they were like, nope, didn't have that thing, and it impacted their ability to have a diagnosis. So what we know is even if people are experiencing criterion A and they have post-traumatic stress, they are not necessarily going to develop PTSD. About 6 of every 100 people, or about 6% of the US population, will have PTSD at some point in their life. Many people who have PTSD will recover and get to the point where their symptoms are no longer meeting criteria for diagnosis or diagnostic criteria. And so the number counts people who have had PTSD at any point of their life, even if their symptoms go away. And we'll talk more in my later slides about the recovery mindset, and really focusing on not forever brokenness. About 5 out of every 100 adults, or about 5% of the US population, has PTSD in any given year. So in about 2020, that was about 13 million Americans. Women are more likely to develop PTSD than men. So about 8 of every 100 women and 4 of every 100 men will have PTSD at some point in their life. Partially due to the types of trauma that women may experience, but we know that sexual violence is not restricted to one gender. That may be part of the aspect of things that lead to higher prevalence for women than men. Go ahead, Shannon. When we look at evidence-based treatment, there are a ton of different types of treatments out there. Some of them have been researched and studied more than others. I wouldn't have the space to talk about all of them. What I focus on are the gold standard evidence-based treatments as designated by the National Center for the PTSD. We know that these 3 treatments have the most research behind them showing efficacy, not only across different populations, across different traumas, repeatability, and several of these, CPT has been widely researched worldwide and in multiple languages, and they've had research done in an active war zone for CPT before, and teaching these techniques to people who don't have a high school education. So we know that the research shows that these types of treatment can work across all types of trauma and populations. The reason that I focus on evidence-based treatments is there are a lot of different things people can do. And sometimes when we look at different types of treatment, there may be folks who are well-intentioned to do trauma work, and the type of treatment or the background of it end up causing more harm than help. And again, we'll touch on that a little bit later in slides. But the 3 main gold standard treatments are CPT, cognitive processing therapy, PE, prolonged exposure, and EMDR, eye movement desensitization and reprocessing. I, after 15 years of the government and being a military spouse, will sometimes fall into acronym speak. So if I throw an acronym out there and y'all are like, I don't even know what she's saying, please throw it in the chat, because I tend to default to acronym speak sometimes, and I will acknowledge that. So brief overview of the 3 types of treatment. So CPT is a written based treatment. It focuses on the 5 main areas that we see change the most after trauma occurs. And those 5 areas are safety, trust, power and control, esteem, and intimacy. And what we know is that we tend to see changes in the cognitions and the way that we understand and approach the world in those 5 areas across the sense of ourself, others, and the world. This is across all types of trauma and again, all types of populations. CPT is super effective when there are guilt, shame, blame, or responsibility stuck points, the coulda, woulda, shouldas. I had a professor in my graduate program that used to say, it's shooting all over yourself and masturbating. And so if people get stuck into those patterns, CPT tends to be a really effective for that piece of it. It really keeps this um, frontal lobe activated when the amygdala is going to the emotion, the rawness response, and really allows people to be focusing in on the cognitions and using Socratic dialogue to see where they're stuck and where things are not effective for them at this point in time. Like I said, it's a really hands-on treatment. It's a written manual. They get a copy of the manual. They're doing the writing in there. There's daily worksheets on stuck points, moving through the whole workbook. It's great for people who really like that hands-on approach, or perhaps people who have memory concerns, and they want to be able to go back to what they've done in the past and kind of look back on those sheets, whether it's, 3 weeks from now or 6 months or 6 years from now. CPT is often done in 12 to 16 sessions, and it can be done virtually or in person. I like to include this in here because, especially in post-COVID era, there's so much virtual. And again, research across all 3 of these shows that the efficacy is the same across modality. So you're going to have the same efficacy, whether you're doing this virtually or via telemental health. There's some considerations that you're going to have to do in terms of like homework sharing and things like that. And like, hopefully you have HIPAA control or HIPAA secured portals or things of that nature. And if people have specific telemental health questions, I will field those as best as I can. The other part of my hat that I didn't mention in my intro is that I developed the telemental health program, specifically treatment into the home for the Boise VA. Developed that program we started that in 2014, and then was responsible for all training and everything like that for all of our psychologists, social workers, and psychiatrists, as well as their prospective trainees. So CPT, manualized, hands-on in a book. PE is prolonged exposure. This is more of an auditory format. So instead of a hands-on workbook like CPT, in PE, we're recording sessions and then they're listening to it in between each session to have the exposure-based aspect of listening. I would say probably 70% of people are like, ugh, I hate the sound of my voice. That's not my game. Okay, that's fine. It doesn't fit for everybody. It's an avoidance-based protocol, or it focuses on avoidance. It's about getting people back into the activities they've been avoiding based on either trauma or lack of motivation. The imaginal exposure, so there's in vivo, which is literally in real life, going out and doing the things you haven't been doing, and imaginal exposure. That section is the trauma processing mechanism, and you're doing repetitive work to desensitize to the trauma response, as well as some similar to Socratic dialogue to do some of the processing. Often completed in 10 to 14 sessions, again, can be done virtually or in person. EMDR is it's focused on working memory taxation to keep the frontal lobe active. And then the easiest way I find to explain it is like getting out of the brain's way of doing the trauma processing it wants to do. Originally, they thought that the bilateral piece of it was really important, and there is an aspect, of course, that kind of hits on both sides. But what the more current research is finding is that the working memory taxation, kind of, again, keeping this part of our brain online and active, is really important, whether you're doing something tactile, whether you're paying attention to changing stimulus on a screen, whatever you're doing to keep your working memory active, then keeps the emotional response, the amygdala response, from being able to just kind of blow the window of tolerance and take you into a place where your brain isn't actually doing the processing. It's often described as a really intense type of trauma treatment. Not everyone experiences it that way, but for a lot of people it is. This one looks very different than the previous two that have the daily work. This one is a lot of internal processing and there's no work between sessions. So this is often where people, for people who are like, hey, I like the repetitive nature. I know that if I do it again and again and again, I'm going to start a new habit. That's awesome. Those are the people that tend to lean towards CPT and PE. And the people who are like, homework's just not my jam. I tend to try to not call it homework because it might like bring back like sixth grade experiences or whatnot. But kind of the work we're doing in between sessions. Again, often we're seeing 12 to 16 session in any one of these 12 to 16 set, like that also depends on if people have any other crises going on in life, if they have things that are causing instability for them, if there's substance use or abuse, anything like that that impacts things. And in occupational injury settings, if there's also a head injury, then some of these things get slowed down a little bit as well, just because of challenges with processing and being able to sort out new information. But that's an overview of each one of the three gold standard treatments for PTSD. Go ahead to the next slide. So how do we then make an assessment on which treatment is going to be the best for each individual? This is never a unilateral decision by me or any other treatment provider, hopefully. We always want to take a look at what their learning styles are, take a look at symptom-wise what's going on for them, and then look at all the different types of treatments and figure out what fits best based on all of those things. So within case one, remember she's a law enforcement officer, early adult, young adult female, and had MVA trauma in response to a situation. For her, when we went through all the treatments, we specifically chose CPT. This was chosen because she had a lot of stuck points about responsibility, blame, and shame, as well as a lot of stuck points about safety and trust, not only occupationally, but also in her real life experience as an officer, experience as a mother, experience in relationships. We did 12 sessions of CPT. She stayed consistent with the protocol. And as we went through treatment, we saw a PCL, which is the PTSD checklist. That is a symptom, an assessment measure, self-report measure that we use to look at PTSD symptoms. We saw a PCL drop of 26 points in the course of her 12 weeks of treatment, which is highly statistically significant. That case, we looked at EMDR as well. She had interest in that piece, and ultimately, because she was having such problems with sleep, and she had also had a TBI associated with the motor vehicle accident, she wanted to do the workbook to be able to have the hands-on, go back to it, look at it in between sessions, and be able to, have that as a resource down the road. Case two was a truck driver. He was involved in an accident. He had both psychological and physical injuries as a result of his accident. And he had a ton of avoidance. He was referred to me pretty quickly within 3 weeks of the injury. And we started our treatment prior to his return to work. We saw a decrease of symptomology from where he had been, and then He had a pretty profound resurgence in symptoms upon getting back into the truck, which just reaffirmed what we were doing with prolonged exposure, the exposure activities, um, and doing small gains on exposure to get him back into truck driving. He did a total of 9 sessions, and we saw a PCL drop of 27 points on him. Again, highly statistically significant. He was a case where, because I started treatment with him prior to him returning to work, we had the time to get back to his workplace first, do gradual exposure, which is exactly what you want to be doing with PE. He was able to go back to the workplace first just to see the trucks, note the anxiety, work on the processing, all the way up to getting into the truck. So we were able to do a lot of that processing before he was in a scenario where he had to get back in and be driving in order to keep his job. Go ahead to the next one. We know that PTSD isn't the only issue a lot of the time, right? For folks who have comorbidities with pain, there's a lot of additional resources like ACT, so acceptance and commitment therapy. Not on here, but a good resource is CBT for CP, so cognitive behavioral therapy for chronic pain, and then clinical hypnosis, a good one for working on nervous system regulation and helping them change the way that their brain understands and experiences pain. When there's overlap between the PTSD and the pain, we still will do trauma work and work to add in pieces for nervous system regulation and pain management along the way. We know that not every person who experiences chronic pain has a trauma or has a experience of trauma that rises them to the level of PTSD. So knowing that there are different ways to go about treating, whether it's chronic pain as a result of just high stress environments and occupational stress, or if it is a result of injury. When we have folks that are comorbid with head injury, there's a lot of things that I love being able to add in, especially in practices that have interdisciplinary teams. When you're able to add in cog rehab, which helps people with, being able to attend to what's going on in therapy, more of that focus, remembering to do homework between sessions, things like that. And coordination with additional brain rehab services, whether that's OT, PT, speech, in the workman's comp world, OPBI through St. Luke's and STARS through St. Al's are both awesome programs that I've been blessed to be able to work with when we have folks that have a lot of stuff going on the brain injury side, and we need to incorporate trauma treatment in that. There isn't anything, and this goes for substance use and abuse as well. There's nothing that says you have to do this one thing first, or this one thing can only come when you've had X months of sobriety or this many months past a post TBI. We want to make sure that we're addressing the distress and the impairment in their functioning. And so historically, there's been thoughts of like, oh, if people are going to do trauma work and they have substance abuse issues, they need to be sober before they can do trauma work. For most people, if we take away the one maladaptive coping measure that they've been using to try to not feel their trauma, it often leads to exacerbation of symptoms, exactly the time you would want to be working on trauma processing. And so when I'm working with folks who are using substances in a way to try to self-medicate their own trauma experience, I will say, hey, I get that this is where you're at. We want to be reducing this. I'm asking you not to use before, during, not that they're usually leaving session, but before or immediately after session, and before or immediately after doing your homework, because we need to build your brain's capacity to know that you're capable of doing these things without the substances on board. So I think that's another piece of when PTSD isn't the only issue to think about, but not a factor in that I would say would impact their ability to to do trauma processing, or they shouldn't be referred for trauma processing. Even in those situations, we would say, please refer them. And then we'd come up with a plan for how to increase their coping skills and resources to be able to manage the trauma processing work. Go ahead to the next slide. I like to spend a little bit of time focusing. Our clinic and my personal view on this is very recovery oriented when it comes to treatment. My background or my slant in this, I will acknowledge, is skewed because of my training within the VA system. Historically, within the VA system, in years past, in decades past, there had been this sense of, okay, you're broken, you're going to be broken forever, you're going to come to therapy once a month for the rest of your life. And that was the myth or the overall perspective that was perpetuated. We know that PTSD is one of the most recoverable diagnoses, and we know that we can get people moving in a direction that shows profound change for them in life. We will also want to make sure that when you're doing that movement, when you're focusing on treatment, that you're doing the appropriate type of treatment. I acknowledge that not everybody in this world is cut out to be a trauma provider, and that's totally fine. Some people are great in all sorts of other areas. I look at other areas of medicine and I was like, dude, that I could not do that realm. I could not do that niche, right? Not my thing. A lot of us within the realm of medicine, behavioral medicine, first responders, law enforcement, all of that, we get into these fields based on the sense of being a helper, wanting to work with people, wanting to see people do better. And when you are doing supportive psychotherapy that doesn't necessarily have trauma processing goals as part of that, it can end up inadvertently reinforcing the avoidance that people are experiencing. When people get distressed, sometimes providers say, oh, I don't want you to be upset or distressed, so let's not talk about that thing. Or I can see how much going to this location bothers you. You can't return to work. It's too much for you. Rather than taking the approach of how do we change the way that you're experiencing things and do it in a way that's healthiest for the patient. Sometimes people have too high of a level of what they've experienced to feel safe in different environments. I get that. I'm not saying that everybody can go back to where they've been before if it's an employment or occupational thing. Sometimes we have to look at other avenues of employment for people, but want to make sure that when you're doing treatment that you're not in a place where you're saying, hey, we're going to just meet weekly. We're going to do this indefinitely. Come in, talk to me about your week, update me on what's going on, and then we'll do the same thing next week. I've had people say, like, I really enjoy treatment with you. I don't want to stop. And I always say, thank you. I appreciate that it feels helpful and that you feel safe in this space. But we're always working towards goals when it comes to what we're doing treatment wise. And if it ends up feeling more like a coffee clutch or a stitch and bitch, then it's not effective trauma treatment or trauma processing work. And so we always look at making sure that if somebody's experiencing supportive psychotherapy, which can be really helpful if there's relationship stuff going on, or learning how to have coping resources, or all sorts of different aspects and things. What's a stitch and bitch? It used to be like little old groups of ladies doing like quilting and just, spilling the tea of what's going on in the little town. We want to make sure that you're doing the appropriate type of treatment for what's going on and not being engaged in a treatment that could end up causing harm. Especially when we're looking at workman's comp treatment, so occupational trauma, and making sure that we're choosing the right type of work for that. Why is time limited so key in terms of return to work? We know that the faster that somebody gets back into the support of their workplace setting rather than being isolated and being home, they're more likely to be successful in terms of getting back into work and staying at work. That being said, we also need to make sure that we look at the status of their relationship with their work. If there's a lot of hostility or negativity about their employment or what happened, their perspective of the leadership at their job because of what happened to them in an occupational setting, often we see a lot of challenges for folks like that in terms of um, uh, progressing as quickly through treatment because there's so much anger and bitterness. Sorry, I'm going to make up some words. Anger and bitterness that are in place for them, that for some folks, moving forward in treatment, it is a little bit more challenging. Doesn't mean that they can't do it, but that's always something that we look at when we're looking at workman's comp cases. Masked treatment is also something that is growing in research support and in popularity. This means more than one treatment session per week. It does not mean 4 times a week for 12 weeks. It means condensing down the length of treatment, but not the number of sessions. So anywhere between 2 to 4 times a week. We know that we've got support, especially with CPT. There are a lot of studies for EMDR is probably the least of the three studied in terms of mass treatment, especially with research through National Center for PTSD and the research that's being done in trauma programs within the VA. But we know that people can move through the trauma program or the trauma treatment more quickly. When we do masked treatment approaches, we tend to see lowered dropout rates, probably because they're starting to see change more quickly. They decrease in their symptomology much quicker because it's more repetitive, or like the intensity or the frequency of it is higher. And they tend to have higher rates of treatment satisfaction. Again, probably because they're seeing gains in treatment faster. Not every clinic is set up to be able to see people 2 to 4 times a week. In the VA, it's more frequent to have it before. I know in outpatient in my clinic here, 2 is usually the most I see in a week. It's a little bit harder for me to do like a Monday, Wednesday, Friday. So I tend to see people twice a week if I'm doing masked treatment approach. Go ahead to the next one. So just threw a ton of information out at you. We talked about in both cases, kind of some of the takeaways, whether it was the guilt, blame, shame, stuck points about responsibility. I will get to your mass treatment question about insurance in just a minute. It is a good question. With case 1, because she had a lot of guilt, blame, and shame, she was doing a lot of responsibility taking about her incident and another officer's trauma experience. That was the best fit for her. She had a ton of gains in the way that she was perceiving things and was able to let go of her sense of responsibility for the death of others. And in the second case, prolonged exposure was the best fit for him because he really just wanted to get back into his truck and to be able to get back in his truck and not panic every time he saw a vehicle coming near him at a stop sign. So being able to process through that, work through graduated exposure as he was getting back into the truck, and that treatment was the best fit for him. So key points in terms of what we've just talked about today. Post-traumatic stress is normal. However, longer-term impact on social and occupational functioning means that it becomes PTSD. Again, treatable, recoverable, and we can see huge gains for folks in treatment when we get them in the right fit treatment for them. Trauma treatment should be evidence-based, and it should be chosen based on symptom presentation and learning styles, making sure that it's a collaborative approach rather than a unilateral decision by clinicians. PTSD does not mean forever brokenness. Um, However, symptoms could be exacerbated if the patient isn't in the correct type of trauma treatment, and we never want to see that. We never want to see people 2, 3, 4 years down the road from treatment and getting worse, not better. Use measurement-based assessment tools. It's what I do in my work here. It's a big thing in the VA as well. Insurance companies want to see it as well, to make sure that you're doing the right treatment for the patient, and also be willing to do them frequently enough that you're assessing and reassessing as you're going through treatment. If you get halfway into a treatment protocol and you see, hey, distress is going up or we're not making impact, that's the time to change direction in treatment, to turn the ship, to move to a different treatment. Not saying, hey, we need to push this through a full 12 weeks and then change course. Making sure that you're assessing and reassessing and shifting treatment as needed as you're moving through. And make sure to address all of the aspects. I like how it added in a word there. I added in a swear word in there. Make sure to address aspects of recovery needs with treatment referrals. So, if you've got folks who are needing occupational therapy, physical therapy, if you're in a clinic or if you're working with a patient and they sign an ROI, I love working in conjunction with physical therapists with an exposure, an in vivo hierarchy, because they often have so many different tools at their at hand for them, and making sure that what you're doing in recovery is like they've been medically cleared to be doing that. So physical therapy can be a great resource for in vivo treatment, and saying like, oh, hey, you had a trauma involving falling off a ladder, getting them to the point where they're first stepping up on a stool, then getting to a step stool, getting to a ladder, a couple rings up. Often physical therapy, especially the folks who do a lot of work within the workman's comp world, have all that set up. And as long as people are medically cleared, work with the other folks on the teams to be able to do as much care as you can. And I'm seeing questions already come in, so I am going to wrap with that. References in case anybody wants to nerd out on all of those things. And then I want people to ask questions. So there's a couple questions I already see. So do you ever have issues getting insurance to cover mass treatment? Insurances are moving towards accepting mass treatment. Our clinic is a private pay model, mainly because of the challenges that exist within the realm of insurance companies. So personally, I don't experience those aspects of things, but that's just because I will tell you that for workman's comp, I do workman's comp cases, and the adjusters for workman's comp love the idea of less treatment time. So I've had zero issues with any adjusters and getting approval of twice a week, because it means that they could potentially be getting people back to work even faster. So that has always been something that's been approved. Are there cases where there's a temporary role for medication? It's not uncommon. I am not a prescriber. I can't speak to whether or not medication is a good fit, but I will often tell people that if they're in a spot where there's so much issue with sleep, there's so much issue with different things going on in life, that it's really getting them to the point where they can't be participating in the treatment at all, that from a conceptual point, I'll look at medications as training wheels. And yeah, if you need training wheels for a little bit to get the ball rolling and get to a point in treatment where it's helpful for you, I think it's totally appropriate if you're working with psychiatry, or you're working with your primary care provider, or NPs, or whoever you're working with, to consider those things. The big things that I would want to have discussions about with treatment team would be making sure that benzos aren't used as a way to not feel what they're trying to feel in trauma processing, or any other meds. I had a patient who was a really big dude. He went to a residential treatment facility, and he was going through prolonged exposure, and there was some disconnect between the treating provider and the frontline medical staff. He would start having responses to the trauma work he'd been doing, and because he was 6'8" and close to 400 pounds of not fat, there were a lot of people that would get really concerned, and he would get shots of Haldol pretty quickly when he was starting to have emotions, and it made it hard for the trauma processing that he was trying to do at that point in time, because then his brain wasn't able to go through. So in cases where they're trying to have the medication decrease their ability to feel, I'd want to make sure that there was a collaborative team discussion on that. Do patients with PTS symptoms that don't meet full criteria for PTSD still benefit? Yeah. So again, if somebody hasn't been 30 days, so in my treatment case too, because he was referred and got into me within less than 30 days before the accident, he was an acute stress disorder case. And he still benefited from this. We can see people who are technically sub-threshold for PTSD, but they have adjustment disorders, still have benefit. Again, it's understanding what is distressful, the stress levels for them, and making sure that you're treating that in what you're doing. It doesn't mean that we're going to, in the VA, we have to be sometimes concerned about people's perspectives of experiences they had that were not genuine, whether it's stolen valor to that level or just symptom exacerbation or exaggeration of what happened in different scenarios. So I'm not saying that anyone could benefit from those, but if you're having distress, clear distress as a result of experiencing trauma processing is going to probably be a good fit for you. Any other questions?
Yeah, let's open it up. We had so many questions come in at once. That was so great. Thanks for addressing those and great presentation. It looks like we had a couple other things. Okay, from Julie, I'm curious about treating people who are unable to not use before or after sessions or when they do their homework. I understand people who can control and they're able to benefit. Unsure about people who are not able to make that choice and are using actively in all phases, including sessions. What are suggestions in this case? My thought is that the substance would need to be addressed first, although seeds can be planted anytime and may be helpful anyways.
Yeah. If people are not in a place where they they don't have the stability to not actively use in terms of immediately prior to, during, or after session or homework, then yes, you would want to focus on the symptom or the substance stuff first. STAIR, so skills training and affective and interpersonal regulation, is a manual that I use a lot with folks in terms of like building coping and grounding skills. It's kind of like if CPT and DBT had a baby. And for some folks, that's a good first start. But I will tell you that Dr. Kate Shard, who's one of the writers of CPT and trained me as a national trainer, Kate Shard is like, nope, like you go ahead and you just get into CPT and they're going to have benefit. And so sometimes people get caught up into that idea of I need to do 6 to 8 months of stabilization first. And if they're actively suicidal or like psychotic or homicidal, like if they're actively in a state where they need a higher level of care than outpatient, then yes, you need safety and stabilization. But I think sometimes people are concerned about people's ability to jump into treatment right away and don't necessarily let your assumption of that hold back. There's a lot of people who can manage more than we think. And as long as we're continuing to check in with them to stability and safety as we go, getting them into the trauma work is definitely indicated. I'm looking at going up. I agree that treatment can be done in timeframes. I am finding that unsupportive family, new stressors coming up, disabilities. So yes, things get in the way, 100%. When we look at fidelity to treatment, you don't want to have more than a couple deviations in sessions. Like if you have a patient come in and it's crisis session, then 100% you deviate off of the treatment. But often the consistency and the structure of the treatment are helpful, and you still can acknowledge like the big stuff that's going on. Like I said, for some people, whether that is complications with comorbidities, the medical fragility, different things like that, you're going to have to be spacing out the treatment in a different way just because of the way that they understand and make sense of things. Um, and can you explain, how do you explain this to the client's parents, if the client, I will say in a perfect world, this is what we're, we have a framework that allows us to kind of stay moving in a direction of progression throughout treatment. I get that things are going to pop up and happen and kind of impact the way life is going. And also, in order to get you to the point where we're seeing the best gains, it's helpful to keep moving in that direction. We're still going to address the things that come up. We're still going to make sure that everyday things are met and make sure that this is the right fit. And for some people, if there's too much going on, diving into trauma work isn't the fit for them at that moment. And that might be something that you find with somebody, is diving into a trauma processing isn't the fit for them at that moment. Any other questions?
I'm curious if any of our panelists have any thoughts for Melissa.
Hey, thank you so much. This is Tara, one of the family doctors. I think my question probably is, I have a lot of people who are either reluctant to engage, or they kind of get started and then it'll like stir things up and they'll kind of panic and stop. I had a guy recently who just couldn't handle going in. And so I guess if there's any thoughts on how, if someone's kind of started that process but doesn't feel, I guess, how to, in a primary care practice or in a counseling, if someone comes in and looks like they would benefit from something more intensive, are there ways you found that people end up being more open to that, or things you would tell them from our perspective?
I do as much education from the front on that as possible. And I'll often refer to it as the concept of blowing a dam, that you've had all this pressure building for years and years and years, and it's really uncomfortable. And you're spending a lot of time right now running across the face of dam with bubble gum, trying to patch up all your holes. When you start treatment, is it going to be more intense? For some people, yeah. Is it going to be more intense at times? I encourage everybody to tell their loved ones, their family members, like, this is what I'm doing. But we know when we blow a dam, the rate and flow and pressure that comes out immediately isn't sustainable long term. And so I am very upfront with people, and I do education about that at the get-go so that they know that that can happen. It doesn't mean that symptom wise it's going to activate for everybody, but I would much rather them know that that is kind of the metaphor of what we're doing, rather than just getting to that point where they're like, oh shit, what's happening? I don't want to do this trauma work anymore. And so I'm really open about that. And I think that the blowing the dam metaphor would be something that could be pretty easily used in primary care as well, of like, yeah, it's going to get intense for a while, but the end goal, I always bring it back around, like you're telling me that you want better connection with your wife and your kids, and you want to be able to make it to a football game or like whatever it may be that like, yes, it will be intense, but the memory of the trauma can't be more traumatic than the trauma itself. We will get through that first month and keep moving through. And yes, there can be folks that drop out of CPT because of that. Well, any of them, right? You're going to have intensity with any of them. But I tend to take the approach of the more I can be open and forthright and do education with folks, the better.
Melissa, thank you so much. This was such a great presentation. As a reminder, those slides are going to be on our website and the recording will be posted later today. We have 1 minute left, so I just want to make this quick announcement. Our next session is going to be Wednesday, March 4th, and it is actually going to be our 1000th Echo session. So really, really exciting and really interesting. Echo really blew up during the COVID era. It was a really highly utilized tool, and for this next session, we're actually going to be talking about post-COVID syndrome and the impacts on mental health. So we're kind of bringing everything full circle. We hope that you will join us and celebrate with us for that 1000th session. Again, that's Wednesday, March 4th from noon to 1 p.m. We have Dr. Laura Mastetti-Opria, who's the Associate System Medical Director for Ambulatory Care with Behavioral Health Services at St. Luke's. And again, she'll be presenting on post-COVID syndrome and the impacts on mental health. So we hope to see you then. Thanks, everybody. Have a great rest of your day. Thanks again, Melissa.
Welcome. Bye.